Welcome to the ASCO Update 2015 here in Zurich. Now we are going to hear the practice-changing studies in genitourinary cancer. Next to me sits Dr. Richard Cathomas from the Kantonsspital in Chur. Richard, which studies in your field were presented which are really practice-changing?
I think there was only one really practice-changing presentation, which was from the MRC group in the UK, and it's about the STAMPEDE trial. And I definitely think their presentation will change practice in the field of metastatic prostate cancer that has not been treated as yet with androgen deprivation.
For which patient group do you think now this applies?
So, STAMPEDE is a complicated trial in the sense that it is a multi-arm and multi-stage trial. So they look at several different treatments at the same time, and they investigated patients who had locally advanced prostate cancer, not treated as yet, and they also investigated patients with metastatic newly diagnosed prostate cancer. And I think the important bit is about the metastatic newly diagnosed patients, and they showed the results on 4 arms of their trial, including 3,000 patients, which is a very large number, obviously. And the standard arm for the metastatic newly diagnosed patients certainly is androgen deprivation, usually with LHRH analog, and so they chose this as their standard arm. The other 3 arms, they compared either ADT, so androgen deprivation, plus docetaxel for 6 cycles, or ADT plus docetaxel and zoledronic acid, or ADT plus zoledronic acid. So this was the 4 arms, and the standard arm included 1,200 patients, and each other arm had 600 patients, so every arm was very large.
What was precisely found?
So what they could show is that for the whole group, including the locally advanced and the metastatic, there was a statistically significant improvement in overall survival of 10 months. But more interestingly, they looked at the metastatic group, which is 60% of the patients, so around 1,800 patients that were included, and they could find a 22 months overall survival benefit, which was clearly statistically significant.
By doing what?
By doing the docetaxel treatment. And the important point is that, and this is a good question actually, because adding in zoledronic acid did not change either failure-free survival or overall survival. So zoledronic acid in this early time point of the disease has no role whatsoever. But adding in 6 cycles of docetaxel early on, so when a patient is newly diagnosed with metastatic disease, appears to significantly improve overall survival. And this was in line with the results presented last year by Chris Sweeney in the CHARTED trial that was presented at the plenary session 2014. And he as well showed an overall survival benefit that was significant. It was 17 months in his trial. His trial was a bit smaller, only 700 patients, and what he did, he had 2 groups, the high volume disease group and the low volume disease group, that was defined by the amount of bone metastases or visceral metastases. And this was not the case in STAMPEDE. So in STAMPEDE, it's all patients with metastatic disease in one group, and they did not subdivide it into the low or high volume disease group.
Okay, so which patients do you really mean?
I think every patient who is fit for chemotherapy treatment, the way that we usually assess it, he certainly is a candidate, and also there needs to be a certain dynamic in his disease. So a patient who is newly diagnosed, who has newly metastatic disease, is in general a candidate for docetaxel in addition to androgen deprivation. On the other hand, if a patient was diagnosed, say 5 years ago with localized disease, was treated for that, has had PSA kind of rising over the last 2 or 3 years, and you kind of watched his small lymph node metastasis growing by 1 or 2 millimeters every year, this is not a candidate for chemotherapy. So the very slow progressors I would not treat, but in a patient who presents newly with clearly metastatic disease, which I would not kind of put a number of metastases on it, and he is fit for chemotherapy, I definitely think it should be discussed.
Now, there were also many negative trials. Which one would you like to mention?
There were quite a few negative trials, and I think the most important negative trial was in localized renal cell carcinoma. And there have been several, I think 4 or 5 trials looking into adjuvant treatment with these novel tyrosine kinase inhibitors. Well, these days not so novel anymore, but at the time when the trials were performed, like 5 to 6 years ago. And the first trial has now been presented, called the ASSURE trial. And again, it was a very large trial, including almost 2,000 patients in 3 arms. So patients who had resection of their renal cell carcinoma, local resection, and were intermediate or high risk, which is everything above T1B, essentially. So most of our patients that are usually treated, they were randomized between placebo or 1 year of sunitinib or 1 year of sorafenib. So active tyrosine kinase inhibitor treatment in the metastatic setting, but in the adjuvant setting, there was no difference in disease-free survival, no difference in overall survival compared to placebo. So this was a completely negative trial, and the only thing it showed is that after 1,300 patients, the trial had to be amended with a reduced dose of sunitinib and sorafenib because too many patients discontinued their treatment. There were too many toxicity problems. And so all we learned is that it is difficult to give TKI in the adjuvant setting, and it is of no use. So of course we have to wait for the other 3 trials to show their results, but I very much doubt that any of the trials will show some benefit.
Any other negative trial?
Well, I think that was the most impressive one. I think we might maybe discuss a bit about the tendency to look into neuroendocrine differentiated prostate cancer. There was quite a bit, 2 presentations about this topic, essentially also looking into what happens if we treat the castration-resistant metastatic prostate cancer patients with these novel anti-hormonal agents, so abiraterone or enzalutamide. And there was a very interesting biopsy study looking into histopathology, but also molecular changes by an American group. And they could show that quite a few of these patients develop negative prognostic features. And they even defined a new term called intermediate atypical prostate cancer, which is not an adenocarcinoma, it's not a small cell carcinoma, but it behaves a bit like a small cell carcinoma. And I think this is something we have to look for in the future. If we have patients progressing on these novel anti-hormonal agents, we might perhaps feel that these patients need further biopsies to find out what's going on.
Richard, thank you very much for the summary of all these practice-changing studies.
You're welcome, thank you.